Go to slideshow, ma'am.
Yeah, slideshow.
Down. Yeah. Thank you. You can
Yeah.
start.
Yeah. Good morning, everybody. I'm Dr. Padma Ravikanti, Senior Anesthetist Consultant at Asian Spine Hospital, Hyderabad. The topic for discussion today is awake spine surgery, anesthesiologist perspective. Now, awake surgeries were performed in multiple surgical specialties like orthopedics, general surgery, and urology, but in neurosurgery, it was limited only to craniotomies. Over the past 2 decades, spinal surgeons have pushed surgical techniques that require regional anesthesia, especially for procedures like endoscopic laminectomies, discectomies, lumbar fusions, and DC stimulator placement or removal. The recent advances in spine surgeries, anesthesia techniques, and pain management has led to the paradigm shift from the conventional open spine surgeries to minimally invasive spine surgeries. Now, coming to the anesthesia for awake spine surgeries, we can do it under general anesthesia, neuraxial anesthesia, or peripheral regional anesthesia in form of nerve blocks. General anesthesia, we can do it under TIVA, which is total intravenous anesthesia, but it has got lot many drawbacks in the form of the patient has awareness and lot of involuntary movements. The neuraxial anesthesia. This is the most common type of anesthesia used for awake spine surgery. It could be done under epidural anesthesia, spinal anesthesia, or combined spinal and epidural anesthesia. The peripheral region anesthesia in the form of nerve blocks. We have multiple nerve blocks like erector spinae block, thoracolumbar interfacial plane block, retrolaminar block, and quadratus lumborum block. But of all these two, the ESP and TLIP are more into use for lumbar surgeries. The regional anesthesia for awake spine surgeries, we shall discuss under the following headings like types, indications, contraindications, technique, advantages and disadvantages, and complications of regional anesthesia in awake spine surgery. Yeah, but most of the things have been discussed by my colleague, Dr. Mahisha. So I'll quickly scrape through the indications for awake spine surgeries. So these can be done surgeries involving a maximum of 2 vertebral levels and surgeries that are minimally invasive or utilize endoscopic technique, surgery requiring neural feedback, aging population, and patients deterred from general anesthesia. But regional anesthesia has some contraindications like surgeries involving more than 2 levels with an unpredictable duration, patient with high risk of respiratory compromise, high BMI, obstructive sleep apnea, pre-existing anxiety or depression. The advantages of regional anesthesia for awake spine surgeries are many, but the most common advantage for a regional anesthesia in awake spine surgery is there's a direct conversation between the patient and the surgeon, and any neurological damage done by instrumentation can be known intraoperatively. Sorry. Yes, it has a few disadvantages like difficult needle placement in epidural anesthesia, inability to obtain CSF in spinal anesthesia, hypotension, post-dural puncture headache, urinary retention, infection, etc. Coming to the preoperative preparation, during PAC, we have a thorough history with the patient about his pre-existing comorbidities, any spine surgeries done before, any regional anesthesias have been taken by the patient. And after thorough counseling and looking into the recent lab values, we post the patient for the surgeries. On the day of surgery, we trolley the patient inside and put an IV access, give a low dose of anxiolytic. The monitors set up are ECG, NIBP, and pulse oximeter. Epidural set, spinal set, emergency equipment, personnel to provide positioning are kept in the operation complex. First, we shall discuss about epidural anesthesia because this is the most common anesthesia we give for awake spine surgeries. This procedure involves injecting a local anesthetic into the epidural space to produce anesthesia sufficient for surgical procedures to be performed without much discomfort to the patient. It can be done either in sitting or lateral positions. We use commonly a 16 gauge or 18 gauge 2-Hoy needle to do the epidural anesthesia. The needle is put into the epidural space and it is confirmed by loss of resistance technique. The epidural catheter is inserted through the needle and it is threaded either cranially or caudally depending upon the site of surgery. Now, the factors which determine the block are the injection site, dose, volume, concentration, position, age, height and weight of the patient, pregnancy, etc. The levels of the areas to be blocked are dermatomes that have to be anesthetized for a particular surgery are decided. The catheter tip is placed in the center of the dermatome, which is to be blocked. The site of needle entry should be at least 1 to 2 vertebral spines away from the intended site of catheter placement, and the catheter length should be at least 3 to 5 centimeters inside the space. Here, I just want to tell you, to start off the epidural anesthesia, initially we give an anesthetic dose which produces a motor and a sensory block, where we use 0.5% bupivacaine 10 ml or 0.175% ropivacaine 10 ml. Once we confirm the block, the patient is taken prone, clean draped, and we give an analgesic dose of 0.25% bupivacaine at the rate of 5 to 7 ml per hour, or we can use 0.2% ropivacaine 5 ml per hour. And the surgery is continued. Next, we come to spinal anesthesia, which is otherwise called a subarachnoid block. This is a procedure which involves injection of a local anesthetic into the subarachnoid space. Spinal anesthesia is reserved for surgeries below the diaphragm and especially the lumbar surgeries below the L1 level. The level of the spinal block depends upon the site of intended surgery. Now, this is the diagram showing how the spinal anesthesia is done. It could be given in the midline, paramedian, or lumbosacral approach. We use a very small needle, 27 gauge pencil point Whittaker needle. Once the space is confirmed by free CSF flow, we inject 3 to 4 ml of heavy 0.5% bupivacaine along with opioids into the space. The purpose of opioids is to prolong the duration of surgery. In spinal anesthesia, when neuromonitoring is done, we don't use spinal anesthesia. As Dr. Mahesha has already informed to us, told us that because there is no motor, there is a motor block, we can't do this neuromonitoring. The next modality is spinal anesthesia. The next modality, is peripheral nerve blocks in the form of erector spinal block. This is the new regional anesthesia technique to provide analgesia for various surgical procedures. It's a paraspinal facial block performed using an in-plane ultrasound. It can be done as a single injection technique or conventional via catheter placement. The needle placement is between the erector spinae and transverse process of the vertebra. The local anesthetic is administered, blocking the dorsal rami of the spinal nerve, thus achieving multi-dermatomal sensory block. This is a slide showing how the erector spinae block is done. We use a curvilinear ultrasound transducer, which is placed in cephalocaudal orientation over the midline at the back of the desired level. The probe is slowly moved laterally until the transverse process is visible. The trapezius, rhomboides major, and erector spinae muscles are identified superficial to the transverse process. So the needle should point posteriorly, inferiorly, passing through the muscles, reaching the superficial to the transverse process. Once the needle tip is below the erector spinae muscle, a local anesthetic is injected. Initially, we give about 5 ml to widen the space, and then we can increment, give a top-up up to 20 ml. For prolonged surgeries, we can put a catheter which is threaded into the space to the top of the anesthetist. The advantages of erector spinae block are: it is easy to perform, better inherent safety profile, target site of the needle is away from the nerve root. But it still has a disadvantage, like there is uncertainty about the comparative efficacy of analgesia compared to the neuraxial techniques. Now, coming to thoracolumbar interfacial plane
Dr.
block.
Padma, we are very sorry. Can you please wind up?
Yeah, this is the last slide,
Thank you,
Doctor.
Thank you. Sorry.
So this involves, this block can be given for lumbar surgeries, where we can see the lumbar paraspinal muscles are multifidus, longissimus thoracis, and intercostalis. The dorsal ramus emerges at the junction between the superior articular process and transverse process, where it splits into 3 branches which ascend and innervate the muscles of the skin of the lumbar area. So the local anesthetic is injected in between the plane of multifidus and longissimus thoracis, which percolates down to the proximally to reach the dorsal ramus. A second injection is given superficial to the posterior thoracolumbar fascia, which further ensures subcutaneous block. So the advantages are TLIP block consistently provides anesthesia to midline lumbar surgeries, and it is speculated that this block can be able to perform reliable pain control for patients having single level or minimally invasive back surgery and decrease perioperative morbidity. Thank you.